Alright, so this is some USMLE GI pharmacology. Let's move right on into the H2 blockers. We got three of them: ranitidine, famotidine, and cimetidine. Well, these are all three competitive histamine receptor inhibitors. So what does that mean? What is that going to do? If I inhibit your histamine receptors, you're going to decrease parietal cell HCl secretion. So who would H2, who would these three drugs be used good for in? People with GERD, peptic ulcer disease, or gastritis. Those three diseases right there is when you want to think about using an H2 blocker on the USMLE. Ranitidine, anything with the dine in it. Tidine, cimetidine, famotidine, ranitidine. And that's pretty much it. So, now there is one thing here with toxicity that you got to worry about. Which one of these drugs of the three do you think you got to worry about with toxicity? Ranitidine, famotidine, or cimetidine? You got it, cimetidine. The sucker right here, he inhibits the P450 system. Remember, he's one of the drugs that can do that. So he's also known to cause gynecomastia because of his anti-androgenic effects. Now, let me ask you something else about this. What do you think the difference is in the volume and distribution of famotidine versus cimetidine since he inhibits the P450 system? Take a minute to think about that. Think about the blood-brain barrier. Think about things like the placenta, etc., etc. Not a dang thing. All three of these can cross the blood-brain barrier. All three of these can cross the placenta. All three of these can cross and get into the skin, the pancreas, anywhere. That's why we're using these histamine blockers. These three guys right here are very fat soluble. So remember that. Alright, moving right along to the proton pump inhibitors. So omeprazole and lansoprazole and omeprazole. What do these both do then? Both of these inhibit the P450 system as well. We got to be careful about that. These irreversibly non-competitively inhibit parietal cell hydrogen potassium ATPase. Therefore, what's that going to do? It's going to lead to decreased acid or HCl secretion. Who are the people we're going to use these for? What patients would you think about a proton pump inhibitor for? Patients with GERD, patients with peptic ulcer disease, patients with gastritis. See a common theme yet? There's the three people we're going to think about using these three drugs, or these two drugs with. So, alright, moving right along. Now, the mechanical barriers, bismuth and sulfate. What do we put these in here for? These coats the ulcer barrier. Are called the ulcer base. Well, therefore, it neutralizes the acid and allows the bicarbonate gradient to be reestablished in the mucosal layer. That's what bismuth and sulfate used for. The triple therapy, you need to be thinking about H. pylori. So the triple therapy is usually going to be, switch colors here, usually going to have a proton pump inhibitor, such as omeprazole, erythromycin, and amoxicillin. Now, what about the quadruple therapy? That's your PPI again, such as omeprazole, bismuth, tetracycline, and the good old-fashioned free radical killer metronidazole. This regimen is used when resistance is suspected in the agents in the triple therapy. That's when you start to use the PPI, the bismuth, the tetracycline, the metronidazole. So you really add a couple things here. You keep the proton pump inhibitors in both of them, but the difference is with clarithromycin and amoxicillin, that's what you really treat H. pylori with. But if you think resistance has been established, you add bismuth to smother the thing. Remember, because he reestablishes and coats the ulcer base. And you add tetracycline and metronidazole. That's how you treat an H. pylori infection. All right, so moving right along, misoprostol. This is a PGE1 analog. This will decrease gastric bicarb and mucus secretion. Also decrease gastric acid secretion. So, who do we use this in? Who do we use to treat this in? You use it specifically to treat those people with peptic ulcers. Those people with peptic ulcers, especially those caused by what? You got it, NSAIDs. NSAID-induced peptic ulcers, you use misoprostol. They also be used to maintain the patency of the PEA. So you can also, besides the NSAID-induced ulcer, maintain PEA, or you can use it to induce labor or terminate pregnancy. When administered with misoprostol, which is also known as RU486, if I'm not mistaken, which is a competitive inhibitor of what? Progesterone receptors. Now, if you get toxicity on this thing, what's going to happen? Well, you're going to get a certain thing called diarrhea, and you're going to get abortive acid. As soon as my color switch here, I'll write that in for you. Diarrhea and abortive acid. Those are your two things you're going to have if you get toxicity on this. Now, alprostadil is another commonly used analog of the PGE1. It's typically used to do what? Maintain PDA. Okay, now let's talk about the muscarinic antagonists, pyrazipine and propanolithine. These block the acetylcholine action at the ECL cells, the M1 receptor, so you're going to get a decreased histamine secretion, and a parietal cell it's going to act on the M3 receptors to decrease HCl secretion. Now, what is, you might say, what is an ECL cell? That's an intrachromaffin-like cell. Okay, so these both block acetylcholine action at the enterochromaffin like cells. Now, what about toxicity with these drugs? What do we got to think about? They're related to acetylcholine inhibition, so you're going to get things like, if you get toxic on these drugs, you're going to get things like tachycardia, dry mouth, things like that. Serious complications of anti-muscarinic toxicity include the 3 C's, which are, I got these in here for you, the 3 C's. These are serious toxicity: convulsions, coma, cardiotoxicity. Which, like cardiotoxicity, what I mean is like you have an increased heart rate, therefore you have less filling in diastole. You're going to go into an arrhythmia. The heart's not getting the blood it needs. Yada yada yada. Now, the oddball muscarinic antagonists. What are these guys? These are antihistamines. TCAs. Quinidine. See why I said cardiac toxicity now. Amantadine. Meperidine. Demerol. Antipsychotics, especially chlorpromazine and thyroidazine. Now with the meperidine, it's an oddball of the opiates. Its mydresis due to muscarinic block. So you're not going to get pinpoint pupils with it. That's why doctors abuse a lot of Demerol. So let's talk about the antacids here. We got aluminum hydroxide, magnesium hydroxide, and calcium carbonate. So what do these guys do? Well, basically, right there in the name, it's antacids. So less HCl secretion. But how do they work? What is the toxicity associated with? The toxicity of antacids is associated with the altered absorption of other drugs, like aluminum hydroxide overuse will cause constipation. It will decrease serum phosphate levels with proximal weakness and osteodystrophy, even lead to seizures. Let me ask you something. If you decrease serum phosphate levels, why are you going to induce seizures? Phosphate ATP, pump's always needed, right? You shut that baby down by decreasing the phosphates available for the pump, therefore you end up with seizures. Now, magnesium hydroxide overuse, instead of constipation like with aluminum, this one's associated with diarrhea. Decreased reflexes, hypotension, cardiac arrest. So the magnesium is much more dangerous than the aluminum hydroxide. Now, calcium carbonate overuse, basically you can chelate other drugs with this. So this guy right here is basically a chelator. You got calcium in the carbonate, you can chelate other drugs that might be in the serum or floating around or something like that. So moving on to infliximab. What do we know about infliximab? He's a monoclonal TNF antibody. Used in what? Crohn's and RA, rheumatoid arthritis. Toxicity related to changes in immune function or reaction to a foreign antibody include infections, fever, and hypotension. Number 1, infection. 2, fever. 3, hypotension. Sulfalazine, what's special about this guy? Sulfalazine is a sulfonamide prodrug cleared by colonic bacteria to yield sulpiridine and mesalamine. So it yields 2 things. Sulfopyridine penicillamine. These are the two things that's yielded when colonic bacteria break it up. You use this guy to treat what? Crohn's, ulcerative colitis, as well as RA. What about toxicity of sulfalazine? What do you got to worry about here? You got to worry about anorexia, nausea, vomiting. Sulfa toxicity. So you can get like a Stevens-Johnson syndrome or a kidney failure, kernicterus, maybe porphyria. How about oligospermia, which is reversible? We all know. All right, antiemetics, moving right on. Antiemetics. Most antiemetics act central to repress emesis. Centrally acting. It's very important that you remember that, centrally acting. So let's talk about the serotonin antagonists. What do these do? These inhibit the serotonin 5-HT3 receptors and are especially useful for nausea associated with surgery and chemotherapy. Surgery, chemotherapy. Some examples include ondansetron, griseotron. Let's put those in there. Ondansetron. Griseotron. Some side effects may include headaches and constipation. What about opiate antagonists? What do? They inhibit the D2 receptors and are indicated more for general use. Some examples include chlorpromazine and chlorpromazine. Moving right along, talking about the prokinetics here. We're going to talk about metoclopramide and erythromycin. Metoclopramide is a D2 receptor antagonist both in the CNS and in the gut. CNS and gut. Dopamine or D2 antagonist. So the CNS actions, what's he going to do? He's going to prevent nausea and vomiting. And the gut action, he's going to be promodal, so used for gastroparesis. Does not induce or not increase colonic motility, so there's no role in constipation. And the toxicity of this guy is going to be extrapyramidal, so you're going to have like motor restlessness, dysphoria, anxiety, facial spasms, dystonic reactions like trismus, and possibly even methemoglobinemia. Now, erythromycin, this is a motilin receptor agonist in the gut as well. Okay, so he triggers the MMC, the migrating motor complex. Here's MMC. Now, you get toxicity on this. This is like macrolide resistance. You're going to get a prolonged QT syndrome or Torsades de Pointes. C. difficile, pancreatitis. Okay, and the last thing, the antidiarrheals. So we got three of them. We got bile acid sequestrants, bismuth sulforates, opioid receptor agonists. So the bile acid sequestrants, how do they work? They bind and sequester bile acids, and they're useful in cases of diarrhea caused by excess bile excretion. So used when caused by excess bile excretion. Okay, so two examples of this drug will be the most popular one, cholestyramine, and cholesterol. So if you ever see one of those on USMLE, those are bile acid sequestrants. Okay, so talking about bismol sulforates. This is used to treat diarrhea, nausea, abdominal cramps, and improves ulcer healing. So it is the active ingredient in the over-the-counter medication, what? Pepto-Bismol. So this is Pepto-Bismol. What does it do again? It's used to treat diarrhea, nausea, abdominal cramping, and the big thing is it improves ulcer healing. Now, moving on to the opioid receptor agonist, these act on enteric nerves. Epithelial cells, and muscle. Decrease GI motility, secretion, and absorption. Absorption and motility. Gotta remember that. They're opiates, man. They slow everything down. So an example, a great example of this is loperamide. It's a commonly prescribed over-the-counter opioid antidiarrheal. It is preferred due to its why. Let me ask you a question. Why is loperamide or loperamide the preferred or most commonly prescribed over-the-counter opioid antidiarrheal? If it's over the counter, it's obviously got a low volume of distribution, therefore it's got low CNS penetration, therefore you can't get high off of it. That's why the USMLE wants you to know that. That's why loperamide is used a lot of times for opioid receptor agonist, the agonistic properties in the gut. And that pretty much sums up GI pharmacology that you need to know for the USMLE.